Hello, my name is Andaria Crespi, and I'm a psychiatric nurse practitioner student at the University of Southern Maine. I'm going to be presenting a case study on insomnia in an elderly woman. So Rita Cook is our patient. She is a petite 80-year-old Caucasian married female who lives at Granite Hill Apartments with her husband of 58 years. Rita is a retired school teacher and she currently receives Social Security. Her chief complaint: I can't sleep at night, I lay awake for hours, and I just can't seem to turn off my brain. Her history of present illness: Rita has had insomnia for the past 2 years, which has become progressively worse over the past 3 months. She describes laying awake at night, unable to turn off her brain. She has been using Advil PM, but she states that it doesn't help much. She was seen by her primary care provider, Dr. Smith, at the Health Reach Clinic on October 15, 2018 for insomnia. She was advised to darken her bedroom and to avoid daytime naps. I've tried all of that crap and it's not working. I need a sleeping pill. I've had Ambien before. Can you give me some of those? So Rita reports that her insomnia started when her husband was diagnosed with prostate cancer about 2 years ago. This new diagnosis has been an added stress for Rita as she has been concerned about his well-being. She has also had to take on more household responsibilities because of her husband's new limitations. Rita reports feeling overwhelmed and unable to cope with these additional stressors. She also expresses that her new diagnosis of atrial fibrillation is stressful to her. Rita's history, her medical surgical history, includes atrial fibrillation in 2016, a history of malignant melanoma in 2000, status post-hysterectomy 1986, and gravida 2, para 2. She's allergic to penicillin. She had a full-body rash in early adulthood, and she's on metoprolol 25 milligrams PO BID and Coumadin per INRs. Family history: mother died of breast cancer at 72 and her father died of a stroke at 68. Socially, Rita lives with her husband of 58 years and she has stable housing. She has several friends nearby with whom she gets together with to play cards. Her 2 adult daughters live nearby and bring her and her husband out shopping and out to eat weekly. Rita does not have a driver's license. She denies any substance use whatsoever. She has a remote history of occasional smoking, and she denies use of alcohol or any other substances. Rita reports that she doesn't get out as much as she'd like to. She walks occasionally, but reports that she gets fatigued quickly. And Rita also reports that she used to enjoy cooking, but lately she's been warming up canned soup and microwavable foods for dinner. Her review of symptoms show that she generally she's reporting an inability to sleep at night and she can't turn off her brain. She denies headache, dizziness, hearing or vision changes, and nasal discharge or sore throat. She reports some dry skin on her arms and lower legs. Cardiovascularly, she denies chest pain, pressure, or palpitation. She doesn't have shortness of breath or cough. She also reports that she has a good appetite, and she denies nausea or vomiting. She denies frequency, urgency, or burning with urination, and she denies arthralgias, muscle aches, or pains. She also denies dizziness, numbness, or tingling, syncope, or coordination issues. Again, psychologically, Rita reports that she's been under a lot of stress lately. 2 years ago, as I had already said, her husband was diagnosed with prostate cancer, and she's been recently diagnosed with AFib. And she reports that she cannot sleep as her mind is constantly running and worried about everything. And Rita denies feeling depressed and says that she's generally in a good mood. She just feels stressed. Objective findings. So for a physical exam, the patient is awake and alert ×3, sitting in her exam room, well-groomed, and she's in no apparent distress. She's pleasant and she's able to attend the interview. Her head is atraumatic and normocephalic. Her eyes are equal and reactive. Pupils are equal and reactive, and there's no nystagmus. ENT is unremarkable. Neck, there's no JVD or tenderness. Cardiovascularly, her rhythm is irregular as she has atrial fibrillation and her heart rate is 88. Her lungs are clear to auscultation bilaterally and she has no crackles or wheezing. Her abdomen is soft, non-tender, non-distended, and her bowel sounds are present. Extremities, no lower extremity edema noted, and she doesn't have any joint effusion. Cranial nerves 2 through 12 are intact. Motor strength is 5 out of 5 in all extremities. And sensory exam is unremarkable. Her gait is intact. Finger to nose test is negative, and coordination is intact. Skin intact, no rashes, dry skin on extremities. Vital signs, unremarkable really. Blood pressure is 138/76, heart rate 88, respiratory rate is 18, O2 is 97 on room air, and temperature 97.8. Labs were not obtained at this time. She's just going where she's getting an assessment of chronic insomnia. It's really not necessary to get labs unless there's a suspicion for comorbid disorder. The diagnosis for insomnia disorder per the DSM-5 diagnostic criteria include a predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms. 1. Difficulty initiating sleep, which Rita has. 2. Difficulty maintaining sleep, characterized by frequent awakenings or problems returning to sleep after awakenings. And 3. Early morning awakening with inability to return to sleep. Additional diagnostic criteria for insomnia disorder include that the sleep disturbance causes clinically significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. The sleep difficulty occurs at least 3 nights per week. The sleep difficulty is present for at least 3 months, and that the sleep difficulty occurs despite adequate opportunity for sleep. Additional diagnostic criteria for insomnia disorder include that the insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder such as narcolepsy, a breathing-related sleep disorder such as sleep apnea, a circadian rhythm sleep-wake disorder, or a parasomnia. The insomnia is not attributable to physiological effects of a substance such as a drug of abuse or medication. And lastly, coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. Treatment goals for insomnia disorder include primary goals are improvement in sleep quality and/or time, improvement of insomnia-related daytime impairment such as improvement of energy, attention, or memory difficulties, cognitive dysfunction, fatigue, or somatic symptoms. Other goals include improvement in an insomnia symptom, so sleep onset latency, which is what Rita has, wake after sleep onset, number of awakenings. So some examples of these other kinds of goals could be sleep onset latency of less than 30 minutes. That would be a reasonable goal for Rita. Another one for somebody else with issues with waking after sleep onset would be waking after sleep onset less than 30 minutes and or decreased frequency of awakening or other sleep complaints. Another goal would be total sleep time of greater than 6 hours and or sleep efficiency of greater than 80% to 85%. And also the formation of a positive and clear association between the bed and sleeping, and improvement in sleep-related psychological distress. The treatment of insomnia initially should start with behavioral treatments. They should be the first-line therapy, and an example of this would be cognitive behavioral therapy, and I'll talk about some other behavioral treatments as well. Also, hypnotics are another option for insomnia in settings where behavioral therapy may be limited or based on patient preference. And it's also important to consider the treatment of an underlying medical or psychological condition when treating insomnia. So behavioral interventions for insomnia include cognitive behavioral therapy. So CBT for insomnia specifically, it's a treatment modality that uses a combination of behavioral and cognitive techniques to overcome dysfunctional sleep behaviors, misperceptions, and distorted, disruptive thoughts about sleep. We also have stimulus control therapy. It aims to break the cycle of problems commonly associated with difficulty initiating sleep. So some basic tenets of stimulus control therapy include only going to bed when sleepy, using bed only for sleeping, and not to stay in bed if unable to sleep after a few minutes. Relaxation therapy is another behavioral intervention that includes self-hypnosis, progressive relaxation, guided imagery, and deep breathing exercises. And we also have sleep restriction therapy, and this strategy is designed to increase sleep efficiency by decreasing the amount of time spent awake while laying in bed. And it also aims to avoid sleep at other times of the day, so discourages nap taking, except for sometimes in the elderly. Oftentimes they need more sleep, so taking a 30-minute nap could be an exception to this. Paradoxical therapy is based on the idea that performance anxiety interferes with sleep onset, and that if a patient tries to stay awake as long as possible rather than trying to fall asleep, then performance anxiety will be reduced and sleep latency will improve. And lastly, good sleep hygiene. So a patient's lifestyle leads to sleep disturbance and problems with following generally accepted practices to aid in sleep. So it's important to talk about this with your patients. Sleep hygiene recommendations. So maintain regular hours of bedtime and arising. If you're hungry, have a light snack before bedtime. Maintain a regular exercise schedule. Give yourself approximately an hour to wind down before going to bed. If you're preoccupied or worried about something at bedtime, write it down and deal with it in the morning. And also keep the bedroom cool, dark, and quiet. Things not to do for sleep hygiene include taking naps. Again, the elderly may have be an exception to this, as they require more sleep just generally. Also, do not watch the clock so you know how bad your insomnia actually is. Don't exercise right before going to bed in order to wear yourself out. Don't watch TV in bed when you can't sleep. Don't eat a heavy meal before bedtime to help you sleep. Don't drink coffee in the afternoon and evening. If you can't sleep, smoke a cigarette. Don't do that. Don't use alcohol to help going to sleep. Don't read in bed if you can't sleep. And also just don't eat, exercise, or talk on the phone in bed. You just really want bed for sleeping. So the medical treatment options for insomnia in the general population, not for the elderly, I just wanted to give an overview of what's being used out there. So for primary insomnia, benzodiazepines can be used, although we're trying to get away from using them, especially because of their abuse potential. Also, you can use Ambien, Lunesta, Sonata, and other hypnotics. Long-acting benzodiazepines such as Dalmane and Doral, those are good for middle-of-the-night insomnia. Short-acting medications such as Ambien and Halcion are effective for individuals who have difficulty falling asleep. And then there's Rosarum, which is melatonin receptor agonist, and it has been used for sleep onset insomnia. So that would be like what Rita has. And melatonin is one of the most commonly used over-the-counter sleep aids that has received mixed results for its effectiveness. And lastly, sometimes sedating antidepressants such as trazodone or Remeron are used. Those are also frequently prescribed as sleeping aids. So again, the list that I just shared of medications that are used in the general population does not take into account medications that shouldn't be used in the elderly. So the Beers list is a list of over 50 medications that are inappropriate for use in the elderly. Classes of medications that are used for insomnia I have here that are also found on the Beers list. So that includes benzodiazepines, both long-acting and short-acting. I have a list here of examples. There are many more though. And the reason for this is that benzodiazepines in the elderly has shown a increased risk of cognitive impairment, delirium, falls, fractures, and motor vehicle accidents. And so then also non-benzodiazepine hypnotic agents such as zolpidem, isoprolol, and zaleplon are also on the Beers list, and these have a similar effect to benzodiazepines if they're used in the elderly. There's an increased risk of delirium, falls, fractures, and research shows there's really minimal improvement in sleep latency and duration. I've highlighted here Ambien because that's one of the medications that Rita was requesting. So again, this is not recommended for the elderly. I put NSAIDs on this list. It's on the Beers list mainly because Rita is taking Advil PM, and ibuprofen is in Advil, and in the elderly, there's an increased risk of GI bleeds and peptic ulcer disease if used. So I'll be recommending that she does not use Advil PM. A few other types of medications that are on the Beers list: anticholinergic medications, diphenhydramine, which is one of the ingredients in Advil PM. These are cleared more slowly with advanced age, and tolerance develops when used as a hypnotic. So in the elderly, there's an increased risk of confusion, dry mouth, constipation. So these are not recommended for the elderly. Antipsychotics, these can sometimes be used for helping people to sleep, especially if they have anxiety as well. But I wanted to put these on here that they are contraindicated and they're on the Beers list because there's an increased risk of CVAs with the use in elderly, and also a greater rate of cognitive decline and mortality for those with dementia. I put so it's both first and second generation antipsychotics. I put examples of second generation antipsychotics because those are the ones I see often being used in dementia facilities that I've been working in. Antidepressants, tricyclic antidepressants. I also have paroxetine on here. So tricyclics are highly anticholinergic, sedating, and they can cause orthostatic hypotension, especially if used in the elderly. So again, contraindicated for the elderly. Okay, so what are we going to do for Rita, her treatment plan? I would talk to her about possibly referring her to a counselor for CBT for insomnia if she's open to it. Otherwise, encouraging her with good sleep hygiene practices and discussing the benefits of maintaining a sleep diary. Also, I would start her on Ramelteon, 8 milligrams PO at bedtime for insomnia. It works by binding selectively to melatonin 1 and melatonin 2 receptors as a full agonist. It is metabolized predominantly by the CYP450-1A2, as well as by CYP450-3A4 and 2C. And the mean elimination half-life is 1 to 2.6 hours. It takes less than an hour to begin working. If it works, Ramelteon will reduce time to sleep onset, which has been one of Rita's biggest issues. It'll also increase total sleep time, and it may also improve the quality of her sleep. If it doesn't work, if it doesn't improve after 7 to 10 days on it, we'd increase the dose, try that, improve sleep hygiene as I talked about, and switch to another agent. Trazodone could be another good option for treating insomnia in the teaching for Rita. I would discuss with her about the benefits of CBT, of course, and especially in combination with Ramelteon. I would also recommend taking Ramelteon an hour before going to bed, with or without food, but not with a high-fat meal, as this could delay its onset of action and decrease its efficacy. Also, I would tell her that because of the actions at the melatonin receptors, they can carry over into the next day and could potentially cause daytime sedation, fatigue, and sluggishness. But this isn't a common side effect, so I would let her know that. And I would also tell her that it has not been shown to cause impaired balance, mobility, or memory. Give her some reassurance. I'd also let her know that there is no abuse potential for Ramelteon. I think this sometimes is really important in the elderly population, especially. Do not want to get addicted to anything. And lastly, I would talk to her about the Beers list and why Ambien and Advil PM are not recommended treatments for insomnia in the elderly, and ask her that she stop using those and try Ramelteon. So that's it. Here are my references. Thank you so much for listening to my presentation.